speaker, Dr. Caitlin Lawlor, first-year resident, will be talking about melatonin has a clinically significant effect on sleep, whether that is a myth or not.
Hi, everyone. So I'm Caitlin Lawlor. Let's see. Okay, first I just wanted to thank Dr. Freed for helping me with this presentation and also starting this series, as well as Margaret Easby from the library. She was a huge help in this as well. No disclosures, as we said. So some objectives for this presentation is first I'll talk about some basic background information on melatonin. I'll talk about the basic physiology of the sleep cycle, quickly discuss the importance of sleep in hospitalized patients, define some key terms related to sleep as well as some key statistics. Then we'll discuss 2 meta-analyses and 1 randomized controlled trial that investigate the effects of melatonin, and then you guys get to decide whether or not we bust the myth. So as for background, melatonin, essentially, it comes from the Greek word melastar, and tonos is the hormone of, so it is the hormone of darkness, also known as the Dracula of hormones, which I think is very fitting for this time of year, nice and festive. It's also known as N-acetyl-5-methoxytryptamine, and it is the most common sleep aid used in hospitalized patients. So it was first derived from the pineal gland of a cow in the 1950s. In the 1990s, it was synthesized in a lab, and it's used for delayed sleep-wake phase disorder, jet lag, shift work, anxiety, especially that related to sleep, as well as sleep disorders like insomnia. So for the biochemistry, it's an indolamine neurohormone. As we said, it's synthesized in the pineal gland, and it's made from the amino acid tryptophan. And so what happens is light activates the suprachiasmatic nucleus of the hypothalamus, which in turn inhibits melatonin production in the pineal gland. So the absence of light, or darkness, leads to the free production of melatonin. When we look at the sleep cycle, there are multiple phases. One is very light sleep. Down to stage 3 is deep sleep. REM is the stage of sleep that is responsible for the bulk of memory consolidation, or at least we think so. And when we look at changes with age, which might be relevant to a lot of our patients, as many of our patients are older, so there's less stage 3 and REM sleep. The REM is spread more evenly throughout the night. As you can see on this graph here, it's typically there's more REM sleep later in the night, and then there's also increased sleep fragmentation as people age. I won't spend too much time here. The point of this slide, though, is that when people are in the hospital, they typically get less sleep. Less sleep can lead to the need for more medications, specifically those relating to blood pressure and glucose control. And then those higher doses that are needed in the hospital can lead to some people getting too much as an outpatient, which leads to problems. There's also a functional decline, possibly related to deconditioning. When people are tired in the hospital, they're less likely to participate in their care plans and be aware of their plan when they leave. So a few terms related to sleep that I'll touch on several times throughout the rest of this presentation. The first is sleep latency. This is from lights out to the time when we're actually asleep. Apparently, the adult average is 10 to 20 minutes. Sleep efficiency is the ratio of the time spent actually asleep to the time spent in bed. And for most people, it's between 80 and 90%. Sleep quality, also known as efficacy, is usually a subjective measurement, and it depends on numerous factors. There's many questionnaires that are used to assess this. Sleep duration, the average adult sleeps under 7 hours a night, somewhere around 6.5 hours, actually, and the recommended is 7 to 9. I'll talk about polysomnography and actigraphy throughout the presentation. Polysomnography is the gold standard for measuring stages of sleep, sleep architecture. People are basically hooked up to a bunch of electrodes. They have a breathing mask on. This needs to be done in a lab. Actigraphy is a small watch-like device that measures movement. It's less accurate, but it can make some inferences to stage of sleep. There are also many studies that just use questionnaires to evaluate sleep duration and latency. Some statistics, so I'm sure you're all familiar with statistical versus clinical significance. Since this is in my first statement, I wanted to just bring light to this. Just because something is statistically significant doesn't mean it actually has a meaningful impact for us or our patients. Mean weighted difference, or weighted mean difference, when we're looking at meta-analyses, it's just the difference of the means between two groups that's weighted for sample size. Standard mean difference is a summary statistic in meta-analyses. It's used to compare results that have different units of measurements. And then we have publication bias, which is the fact that articles with positive results tend to be published more than those with negative results. And heterogeneity, I can explain better with a graph or a picture than with words, really. But we want low heterogeneity when we're comparing trials. So in this first picture, you can see that the results, if we draw a line straight through the center, that gives a pretty good description of where those results lie. In the second picture, a line straight through the center doesn't really accurately describe any of those results, so they're less comparable. So my first study was a meta-analysis, and it's looking at treatment of primary sleep disorders. So these are randomized placebo-controlled trials. The sleep disorders in this study were insomnia, delayed sleep phase, and REM sleep behavior disorder. There were over 1,600 patients overall, and then they've investigated publication bias and heterogeneity in all of the studies. The outcomes that they looked at were latency, total sleep duration, and quality. Inclusion criteria, as we talked about, we already mentioned the disorders that were involved. Examine the effects of melatonin. We discussed that they're randomized placebo-controlled. They had at least 10 participants in parallel, 5 in crossover designs, and they had to be published in English. So our first measurement that we looked at was sleep latency. So in the melatonin group, overall, sleep latency was improved by 7.06 minutes. So people fell asleep 7 minutes earlier, and that was significant. However, they did a subgroup analysis, which I think was very important in this study. The latency that was measured objectively, that's with actigraphy or polysomnography, it was only a 2.2 minute improvement, whereas subjective, it was 10 minutes. And this could be due to measurement bias. Of note here, heterogeneity was high in both the overall and subgroup analysis, so it's sort of difficult to come up with one statistic to describe all of these results from the different studies. Next, they looked at total sleep time or duration of sleep. So in the melatonin group, the sleep time was 8 minutes longer, and this was significant overall. However, again, when we look at the subgroup analysis, the objective sleep time improvement was 0.33 minutes, which is 19 seconds, and it was not significant. So here, the results of the overall are heavily influenced by the subjective measures. Then they looked at sleep quality. So this was done with multiple different sleep questionnaires, which is why they had to use the standard mean difference. I had a lot of trouble at first, figuring out, okay, what does a standard mean difference of 0.22 really mean, for us? And statisticians say that a standard mean difference of 0.2 is low, 0.5 is medium, and 0.9 is a large effect. So this is a low effect. However, again, when we look at the subgroup analysis, the objective group did not have an improvement in sleep quality. My second study was another meta-analysis looking at the effects of melatonin on sleep. These were 17 studies, randomized and double-blind. So important here is there were no severe disabling systemic disease, which is very vague, and they didn't define what this meant. But what it means for us is none of these patients were inpatient. These studies were all either done at home or in a sleep laboratory. And this was all objective measures. So in the last paper, I talked about objective versus subjective. These were all done using polysomnography or actigraphy. So the population was healthy volunteers, people with insomnia, people who were institutionalized and independently living with insomnia, patients with schizophrenia, and patients with Alzheimer's disease. They looked at sleep latency, duration, and efficiency. So that is that ratio again of time spent asleep to time spent trying to sleep. So for onset latency, there were 13 studies that measured this, but interestingly, they only included 11 in the final analysis. Of those 11, they found a 7.5 minute improvement in sleep latency. However, when they looked at all 13, there was only a 4-minute improvement. This is still significant, but interesting that they decided to exclude 2 of those papers. When we look at efficiency, there was a 2.2% improvement in efficiency. Now, I had no idea how to put that in real words, so I did a little math. So if average sleep efficiency is, we'll say 80%, it's actually less in hospitalized patients. And let's say we try to sleep for 8 hours a night. I think that's a reasonable goal. That means that 6 hours and 24 minutes is actually spent sleeping each night. A 2.2% increase in efficiency means there's an extra 8 minutes and 27 seconds of sleep per 8 hours at 80% efficiency. The last statistic in this study was total sleep duration. So melatonin did improve the total sleep duration by 12.8 minutes, and this was statistically significant. Interestingly, though, when you actually look at the graph here, only one study individually was significant for improvement, although overall they were significant together. And again, this paper reported 9 out of 17 studies that talked about efficiency, but only 8 are included in this final analysis. They didn't specify why one wasn't. My last paper is a randomized controlled trial, and this is looking at melatonin supplementation and sleep quality and serum melatonin concentrations in ICU patients. Of note, so as it says, this was a 7-day consecutive nights of 10 milligrams of melatonin. Some of these patients were discharged from the ICU prior to 7 nights, so their trial was continued on the wards. And this was also double-blind, randomized, placebo-controlled, over 200 people, done by an intention to treat analysis, so people that stopped taking melatonin for various reasons were still included. The primary outcomes were the number of hours per sleep number of hours sleeping every night. This was reported by ICU nurses who paid close attention at bedside. Sleep quality was assessed through a questionnaire. The prevalence of delirium was assessed by ICU nurses according to the, it's in my notes here, an ICU delirium measurement scale. And then the plasma melatonin measurement was also done by ELISA. So just before I summarize this one, it's breaking up ICU versus ICU and wards. So the top part of the graph is patients that only spent their 7 nights in the ICU. The bottom was these patients had a mix. And interestingly, in both of these groups, the people receiving melatonin had more nights of poor sleep and fewer nights of good sleep. They also had fewer nights of poor sleep and more nights of good sleep. So these are somewhat confusing results. When we look here, this is the Richards-Campbell Sleep Questionnaire, which assesses multiple components of sleep. And so they split it up a little differently. They did ICU nights of sleep versus wards nights of sleep. So they separated them out. And overall, more nights were spent on the wards. Or on the ICU, sorry about that. So sleep depth was significantly improved in the melatonin group, but again, only in the ICU group, not on the wards. Sleep latency, there was no significant difference. Awakenings, no significant difference. Return to sleep, overall no difference, although in the ICU group there was some improvement. There was no difference in sleep quality overall. And the total score on this questionnaire, there was a significant improvement in the melatonin group, although this was only seen in the ICU, not the wards. And this second graph here, it isn't anything out of, that we wouldn't have expected. So melatonin concentrations were higher in the group that received exogenous melatonin, except for at 6 o'clock the following day, the difference in melatonin concentration was no longer significant. So other outcomes here. So 63 patients experienced adverse effects. None of these were deemed to be serious or life-threatening. 8 patients dropped out. Only one of them was actually in the melatonin group. So there was no significant difference in the duration of sleep, the prevalence of delirium, the requirement for analgesia or sedation, which was done on the Richmond Agitation Sedation Scale, the prevalence of pain or anxiety as assessed by ICU nurses or psychiatrists. And this wasn't a primary outcome, but they also looked at mortality, no difference in mortality that was significant. So to summarize everything that we just talked about, we looked at 2 meta-analyses, 1 randomized controlled trial. These studies cover a varied group of patients. I went pretty broad here. So some of these patients were in the ICU, there were days on wards. Many of these people were outpatients, some were measured at home, some in sleep laboratories, and there were other sleep disorders, cognitive and mental disorders included in this population. Measurements were done subjectively and objectively. They were all double-blind though. Outcomes of interest were latency, duration, quality, and efficiency. And I'm gonna summarize some of these on the next slide. So when we looked at our first study, I'm focusing on the objective measurements just because I think that those were probably a better way to assess. There was 2.2 minute improvement in latency, no significant difference in duration, no significant difference in quality. In the second study, a 4-minute improvement in latency, 12.8 minute improvement in duration, and a 2.2% improvement in efficiency. So that's, again, another 8 minutes and 30 seconds. In the final study, there was no difference in duration, and the differences in sleep quality were very mixed, so I wouldn't put too much into those. So I outlined in green the ones that were statistically significant, or at least that I deemed to be significant. And then in red were the ones that did not work in favor of melatonin. So at this point, I'm going to ask you again to remember clinical significance versus statistical significance. So these numbers in the purple circles, 2.2 minutes, 4 minutes for falling asleep earlier, and then 12 minutes increased duration, 8.5 minutes that you get extra with sleep efficiency. Are these numbers actually clinically significant for our patients? If we think of someone getting about 6 hours to 7 hours of sleep a night, does 12.8 minutes make a huge difference?
Does anybody have any questions or comments? And I'll have to ask you to use the microphones if you can. There's one right behind you. Yeah, go ahead.
So I saw in the ICU trial, it was just looking against placebo. Did any of the RCTs mention, did they ever compare melatonin to placebo to not getting anything at all?
That is an awesome question that I had myself, and most of the trials did not compare to no treatment, because I think in this case, placebo probably does have an effect on sleep. If you tell someone, this pill is going to help you sleep, it's a sleeping pill, and they believe you, their anxiety about sleep, which can be a major thing that keeps people up, goes down a lot. So they actually didn't look at that.
In those studies previously, did they talk about average sort of duration of taking the melatonin? Just because I guess I've heard from different sleep medicine physicians and read online that because it's sort of acting as a hormone to help you sleep, you got to take it, for several weeks in order for it to even begin to have an effect. And I don't know, when they gave them those surveys or when they ended up asking them, or if you had any more information on that.
Yeah, so those were also questions that I had throughout my research. And because the meta-analyses look at so many different trials, and the meta-analysis themselves didn't actually state, when did they ask the sleep questionnaire? That's important, right? If you're asking at 8 p.m. the next day, people aren't going to remember. They also didn't report the overall average amount of sleep for patients in the hospital, which is very different from, at home. People sleep a lot less in the hospital. And I think, quantifying, 8 minutes of sleep compared to 5 hours or compared to 7 hours, maybe it doesn't make a huge difference, but I think it's important to note, and these meta-analyses didn't report that, neither did the randomized control trial.
Sorry, let me reframe. I think I more so meant the duration of how long they took the melatonin, how many days or weeks, et cetera, not how much time.
Oh, I see.
Yeah.
So for the randomized control trial, it was 7 days. For the meta-analyses, they didn't state the range. I think my understanding is that some of these trials were only maybe a week, and some were up to a month, but they didn't actually give a range of how long. And I think that is important as well when thinking about setting habits and sleep schedules and getting used to the effect of the melatonin.
There was one trial that I looked at when I was reviewing things that I looked at, and unfortunately I can't remember which one it was, but it was a randomized controlled trial where they had a 4-week period of either placebo or melatonin, a 4-week washout period, and then another 4 weeks, and they didn't have any significant differences even after 4 weeks.
So just going to repeat it for this. The question is, are there any individual differences in response to melatonin? Do you mean like different people? Yeah, person. So the trials that I focused on didn't break down subgroups of, let's say that one trial that had healthy people versus people with insomnia and a few other populations. They didn't break those down into a subgroup analysis. And I know that there are most of the randomized controlled trials around melatonin are done in convenient populations. So ICU nurses that work night shift, or soldiers that are up at night for, a drill or something. And so in those populations, I'm sure that there are, in people with jet lag, maybe it works differently than people who just have insomnia. I didn't come across anything that stuck out to me, though.
Great job. All right, so I guess it's time to vote. Melatonin has a clinically significant effect on sleep. How many people think that this is true? How many think it's plausible? A lot. And how many think it's busted? Okay, well, I think the plausibles have it. Good job.